Hi, everybody. It's 7 p.m. in Paris, 6 p.m. in London, 1 p.m. in New York. And it is my great pleasure to welcome you all to this first journal club of the year 2022 by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital. And I'd like first by wishing you all a happy new year 2022 and lots of best wishes for a safe, healthy, and joyful new year. Hopefully this new year will witness the end of this COVID-19 pandemic, and we will be able all together to go back into a certain normality. However, despite the difficult circumstances, and I have a special thought to all patients and families and all colleagues who are really struggling and fighting against this COVID pandemic. Despite all this, as you all know, the ICH activities continue, and this is going to be our first journal club of the year. I'd like to acknowledge Takeda Oncology for their unrestricted support for these activities. And the steering committee, the scientific steering committee of the ICH has selected this very recent article published in the Journal of Clinical Oncology entitled Randomized Phase 3 BMT CTN Trial of Calcineurin Inhibitor-Free Chronic Graft versus Host Disease Interventions in Myeloablative Hematopoietic Cell Transplantation for Hematologic Malignancies by Dr. Leo Luznik and colleagues. And to discuss this article, we are very privileged and honored having the senior author, Dr. Miguel-Angel Perales from the Memorial Sloan Kettering in New York. And the discussant, as usual, is an expert who did not participate into the study, namely Professor Didier Blaise from the Institut Paoli-Calmette in Marseille in France. Just for the sake of introduction, as it is always a tradition in these journal clubs, I'm showing the abstract of this very great effort, and I would say the BMT CTN colleagues who performed this trial should be congratulated for running such a huge effort. You will see the amazing number of patients being included and some very important conclusions. And to make a long story short, actually they have randomized patient with acute leukemia who received a myeloablative conditioning up to age 65 from a related matched or unrelated matched donor into a 3-arm study, either a control arm with tacrolimus methotrexate GVHD prophylaxis versus 2 experimental arms, one with CD34 selection, sort of a T-cell depletion, or the more frequently used now, more and more popular standard post-Cy. And the key conclusions from the trial are shown here in red, that a calcineurin inhibitor-free interventions with post-Cy or CD34 selection were not better than tacrolimus and methotrexate when you use unmanipulated bone marrow in the HLA matched transplant setting. In addition, another conclusion is that there is an improvement of chronic GVHD prevention did not translate towards a better survival. So I already mentioned the procedures. The patient were up to age 65. These are acute leukemia in morphologic remission or MDS with little infiltration with blast. And you can see the 3 standard of care, TAC and methotrexate, and this is with the up to day 11 methotrexate, 13611, the historical way of doing. And you can see here the chronic GVHD relapse-free survivals showing no difference when you compare the experimental arms to the control arms. You can see the overall survival curves. Obviously, the blue curve is lower than the others, but this is not statistically significant, but we'll discuss this later. Incidence of chronic GVHD, definitely the CD34 selection is an important tool to reduce chronic GVHD. You can see the incidence of non-relapse mortality or transplant-related mortality. And again, here you can appreciate that in contrast, the CD34 curve is the upper curve. But again, obviously, we will discuss all of these issues. The incidence of relapse may be a trend in favor of post-Cy. And when you look to relapse-free survival, again, you can see the trends in favor of the post-Cy. So with these introductory statements, I'd like to welcome our top expert. And so Miguel, good morning or good afternoon. Didier, good evening. Thank you for joining this journal club. And usually my first question is to the expert who did not participate into the study. What was, Didier, your feeling when you saw this trial being published, when you read it? Did you say, oh, wow, this is amazing? Especially that I think in the 90s, you have contributed a lot of trials in the field of T-cell depletion. So that should bring some good souvenirs, I would say. So please share with us your feeling. And by the way, I'd like to remind all the participants, the colleagues, that you can send your questions, and I'll do my best to share them or your comments with the panelists. So Didier, the floor is yours.
Yes, thank you, Mohamad, and Happy New Year to everybody. So I'm very pleased to be here. And really, when I saw the first time the title and the abstract, I say, whoa, that's interesting. That's one of the trial we needed. Why? Because in fact, we try to we are all living with what we have done previously. And this trial, the inclusion of the patient, if I am not wrong, started in 2015, meaning that we have really recent data and a recent patient. And so it's necessary to have this kind of data to compare what we want to do and to have the reality of the present days. That's the first thing. The second thing is that a large number of patients, and there are 3 arms. We are always talking about CNI and methotrexate. And it's true that we have never really done a contemporary comparison with T-cell depletion. And as compared, and you mentioned that many years ago, many of us were involved in T-cell depletion, but we have never, now we have tools allowing to do a simple T-cell depletion, the CD34 selection. And we can do that nearly in all programs. So that's interesting to figure out what it is with once again, the present treatment of the patient. And the third thing is PTCY. We all use PTCY. There is a lot of debate concerning PTCY in this situation. So that's true. I was really very excited about what are the results. And the trial have been really very well conducted. Now, when you look to the result, it's a little bit far from my own practice when I see the different. And I do think that we will discuss different aspects during this session. Why? Because first, the question of age. Median age of the series is about 50, which is much younger of what I am doing at the present time. Median age in my program is around 62, so it's far. Second thing, it's bone marrow. and it's crucial in this situation. And bone marrow, except for the CD34 selected arm, but for the two other things, it is bone marrow. And I never use any more bone marrow in most of the situation. And I do think that in Europe, it is people are doing the same things that what I do. So that's a second aspect. And the third aspect is the use of ATG. There is no ATG in the two arms. And as you have seen in the paper, it's HLA match transplant, but many people in Europe use ATG in unrelated transplant. And even in our program in Marseille, when we use match sibling transplant, we also use ATG. So it's a little bit far from what we are doing, and we need to discuss these different aspects to see what we have get from this trial.
So thank you, Didier. Definitely, you have highlighted some of the specific issues. The devil is always in the details. But I'd like first to ask you, Miguel, and again, I'd like to congratulate you and the colleagues, Leo, Marcello, and all the colleagues who did this really beautiful work for really achieving such an important trial. Can you just remind us, Miguel, why did you develop this trial? What was the rationale behind it? Because obviously, as Didier mentioned, in the myeloablative setting, CNI plus methotrexate is really well established. You know, people consider this as a standard of care. So why did you want to challenge this?
Sure. Thank you again for inviting me, and Happy New Year to everyone. So I think Didier has clearly illustrated or highlighted many of the questions we had in designing the trial. What should the control arm be? Why did we pick bone marrow? Why in the PTCY arm did we pick bone marrow and did we not use TACR-MMF, which is what a lot of people are using? Why was there no ATG in the control arm? So these are all the discussions that we had, you know, over a decade ago when this study was designed, because this was designed probably in 2012 is really when we sort of finalized the design of the trial. You know, so we tried to, as much as we could, go based on randomized data. So the CTN had done a study that Claudio Anicetti had led and was a plenary at ASH and published in the New England Journal, which showed that in the match-stem-related donor transplant, that bone marrow was better than PBSC in terms of reducing chronic GVHD. And actually, there was a long-term follow-up paper published by Stephanie Lee that showed that patients who got bone marrow in that study actually had better quality of life and were more likely to go back to work. So that study, as you all know, and similar to what Didier said, didn't have a big impact on the field because a lot of us continue to use PBSC. But we felt that if we were going to do a trial, that the control arm had to be the one that was superior based on phase 3 data. And to just say, well, we did a trial, we can ignore it. It was phase 3, and just do a new trial using a standard of care that people use, but it's not superior based on phase 3 data, didn't make sense. And in bone marrow, people haven't used ATG. There was a lot of discussion about whether we should have bone marrow as one option with tacrolimus and PBSC plus ATG tacrolimus as a second option. But that really was two different questions, and then we would have to increase the sample size to address that. So the control group was really dictated by BMT CTN 0201. And then the experimental arms, the post-transplant cyclophosphamide arm was really dictated by the experience published from Johns Hopkins, which was an ablative transplant with bone marrow and PTCY. A lot of the world has moved on to using PBSC in the PTCY setting. And in that setting, certainly in RIC, we always use, you know, TACR-MMF or CNI-MMF. And in the ablative setting, many people have gone to using that as well. And the CE34 arm was based on the experience at Memorial, and at least that's how we were doing it then. We have since changed our approach to CE34 selection, particularly in the timing of ATG. And rather than giving ATG close to the graft, day -3, -4, we now give ATG early. And those of you who are familiar with the literature know the work that J.J. Boulens has done in Utrecht and now here in New York, showing that if you give too much ATG, you have delayed immune reconstitution. And so that's how we ended up with the design of each group in the study. And so I think the big question is how do we apply the results to our practice today?
We'll come to this, Miguel.
Yeah.
So thank you for clarifying this. So we have one question here from the audience about the 3-arm design, because you mentioned that the trial was designed in 2012, 2013, and for me, this is when we got all the enthusiasm about post-Cy. So my best guess would be, okay, let's compare our historical standard of care, CNI plus methotrexate or MMF, to post-Cy, especially that we have another question that although you're using post-Cy, but this is not the post-Cy that was developed by the Hopkins and by Leoluznik, Ephraim Fuchs, and all the team, because you did not include CSA MMF or TAC MMF. Obviously, I'm aware that your goal is to have a CNI-free approach, and we'll discuss this later. Why do we need a CNI-free approach, you may say. So why did you include the CD34 arm, whereas it is a more restricted approach only in a few centers?
So actually, the CTN had done a trial, 0303, which was a CE34 Selection trial, phase 2, single-arm study, 45 patients, that I think Steve Devine was the first author on that paper. And that was the first paper to show that we could do CE34 Selection the way it's done in New York in the multi-center setting. And the results of that trial were consistent with our experience in New York. So 1301 was originally a trial to ask the question of, in the randomized setting, of CE34 selection. But for the reasons you mentioned, that's also when we were talking about post-Cy. Post-Cy actually got added to that study, as opposed to it being a study of post-Cy where we added CE34 selection. And at the time, you know, going back 10 years ago, if you look at the Hopkins experience, in the match setting, with an ablative transplant, they were not using CNI MMF. They were just using post-Cy with bone marrow. Now, in retrospect, maybe they would have been better off if we had, you know, some CNI MMF in that arm. Maybe then it would have been better than the control. But we did the study based on the data we had at the time.
Excellent, thank you.
May I ask a question to Miguel in this perspective?
Please do.
It's concerning the CD34 selection. I mean, that's an interesting way to select the graft. But nevertheless, at the end of the day, even in this trial, we still stick with high transplant-related mortality. And if I notice well, there is no statistical difference, but there is a trend for older patients in this arm with more comorbidities. And the natural thing, because we prevent very well chronic GVHD, would be it could be a real option for older patients. However, because of the transplant-related mortality, that's a big issue. Can you comment on that?
Yeah, no, I think obviously, you know, as a proponent of CE34 selection, you can imagine that I was not completely happy with the results of the trial. And that when I opened the email that we got from the DSMB, when we first found out the results, you know, that survival curve was not a curve that looked great. I think, you know, the primary endpoint, all 3 arms performed the same, which was the chronic GVHD relapse-free survival. But there was a higher rate of non-relapse mortality in the CE34 selection arm, and that resulted in lower overall survival. And so I think the big question then is what was leading that. And, you know, I think there was some trends toward differences between the groups, but it doesn't account for the difference. I think there was, you know, probably a learning curve, because we went from, you know, a center that does a lot of CE34 selection, Memorial, to doing multi-center. And so there are patients who got DLI that we would not have given DLI for mixed chimerism. There were patients, a couple of patients who got an EBV lymphoma that were not treated the way we would treat them. But that's, you know, that's the real world, right? When you want to do a phase 3 trial, you have to accept those considerations. And I think inherently there is a delayed immune reconstitution, and I think that's associated with a higher risk of infection and ultimately non-relapse mortality. I think the surprising result for many of us who participated in the trial was that the control arm had a very low non-relapse mortality at 1 year of less than 10% for an ablative transplant.
We'll come to this, Miguel, because we have lots of questions here. I would like to tackle the issue of age and conditioning, because Didier alluded to this, where actually this trial allowed fully myeloablative standard conditioning regimen up to age 65, although the median was closer to the 50s. But Didier, and you mentioned that in your program, the median age is above 60, and I think this is a trend almost everywhere. Even I think the CIBMVR colleagues, but also the EBMT recently have published now papers about patient being transplanted without age 70. So now that's 70 is becoming like our new bar, I would say.
I saw a patient this morning who's day 21 from allotransplant for AML. He's 78. He was discharged yesterday.
Fantastic.
So,
yeah, I think physiological age is criteria. So what is your approach, Didier, in terms of conditioning when you have to transplant these so-called elderly patient? And I think this is in line with a question we had from Dr. Avenoso Daniele from London at King's College, who is asking about also the impact of comorbidities there. So how would you, what is your current approach?
For the older patient, really older patient, I would say above the age of 70, we usually use a real non-myeloablative regimen. But we have to realize that treating patients above the age of 70 is associated with a huge selection of these patients. We don't treat all patients. The question is not really to do a transplant for all these patients, but will the transplant do something will be important for the patient? And of course, the selection is important. And so I do think that we cannot do the transplant program in older patients without developing tools as oncology evaluation, different kind of scale we have to use. And for the patient, so I say, for the patient above 70, we rather use non-myeloablative regimen. For younger patients, we are either, according to the comorbidity, using the same non-myeloablative regimen or try to develop a more potent approach using PK guide busulfan associated with ATG and fludarabine.
Okay, thank you. Same question to you, Miguel. What is your standard conditioning approach today, and what kind? Because we'll go back to the bone marrow issue because we have a few questions about this. The most common practice, despite I think it's a pity the randomized trial is about PBSCs. So what is your approach? And let's avoid the 70 or 75, but let's take a 66 year-old patient with AML in first CR, morphological CR.
I think for us, the approach has continued to be the same, that we think that there is value to ablation in the patient with AML. And I think that was demonstrated in the Maverick trial, 0901, which was published also by the CTN and JCO, which clearly showed a tripling of the relapse rate in patients with AML who got a RIC versus MAC. And a decrease in the overall survival. Now, obviously, you have to be eligible for an ablative transplant, and then that often has to do with age and comorbidities. But in the fit, patient who's 65, I would feel comfortable doing an ablative transplant. Obviously, historically, we have done T-cell depletion, which is always ablative, up to the age of 70 in patients with an HCT-CI of 3 or less. In the more recent era, Ronnie Schuval, who you know well, from his work at EBMT, has actually looked at our data and has developed a new and updated comorbidity index, which is sort of looking at the factors that Mohamad Sora looked at in the original ACTCI, and shown that the pulmonary function and the liver function and the heart are probably the three critical organs in terms of comorbidities. And that using those three, particularly, and then creatinine clearance, you can better distinguish and discriminate patients who are eligible for an ablative transplant versus not. But one of the advantages of T-cell depletion, aside from the reduction of GVHD, is that you're not using methotrexate. And so that in of itself, an ablative transplant with methotrexate, I think contributes to the toxicity of the regimen. And so I think today, if I had a 66-year-old with AML CR1 with a good performance status comorbidity index, we would still do a T-cell depleted ablative transplant, chemotherapy based. We've also moved away from using full body TBI, high dose TBI. And as I said, we've modified our ATG and we're doing PK directed ATG.
Excellent, thank you. So we have a question for you here, Didier. And so based on the results of this trial, do you feel comfortable using post-Cy alone in a certain number of patients where you don't want to give a calcineurin inhibitor? And then I'll ask the question about, but actually, why should we get rid of calcineurin inhibitor? I think we've been all using cyclosporin or tacrolimus, and usually now more and more the drug is discontinued relatively early, between 3 and 6 months, closer to 4 months and 6 months. So why we absolutely want to get rid of CNI? But first, Didier, does this trial gives you confidence in some patient to use post-Cy alone?
In fact, we do. And it's basically for the patient with impairment of renal function. When the question came to the fact, can we do the transplant or not do the transplant because of the renal function, we tried to consider to do a bone marrow transplant and use calcineurin-free transplantation. Even if we may consider at time of potential GVHD to add calcineurin inhibitor after transplantation, if needed. But we do that with appealing results.
Excellent. So, Miguel, we have one question, and this is something I think that you have discussed extensively, or at least, in my opinion, it has contributed maybe to, I don't know whether we should call them disappointing or unexpected results. And this is in relation with the toxicity and the transplant-related mortality at 2 years of less than 8%, 7.9% for the tacrolimus methotrexate, again, myeloablative conditioning, up to age 65, including MDS patient. I have seen even a couple of CMML. So, and actually, your trial was designed and the calculations were powered based actually on the registry results of the tacrolimus methotrexate practice, which were almost half what you found in this trial. So how do you explain this? So is this in line with the common dogma that patient and trials are highly selected, and then obviously they do not reflect the real life and the registry reflects the real life? So how can we explain this? Because I read this paper several times, but I couldn't find an explanation why.
Yeah, I mean, this is a good example of where the control arm does much better than expected. And as a result, the study ends up being negative. We spent a lot of time trying to understand that, as you can imagine. Marcello Pasquini published a paper in BMT a few years ago looking at these different composite endpoints, the CRIFs and the GRIFs, and that was the basis of this trial, the sort of the control group. Unfortunately, that control group in the registry included PBSC. And so I think, that was part of it. I think part of it was the PBSC inclusion versus, straight bone marrow. A registry versus a randomized trial, I think, may have played a role in it. But remember, this was a study that was open at 29 centers in the US and a few centers in Germany. I think we can't blame it all on sort of, cherry picking of the patients for a multi-center trial. I mean, this was, obviously we would expect it to be better than registry, but I don't think you can explain that big of a difference with the registry data. I do think this reflects for the control arm, data that if we all use bone marrow, maybe would be closer to the real world. We've chosen not to use bone marrow.
Excellent, thank you. Or maybe also another explanation is that the learning curve now with this classical historical approach is very, very good. And for instance, recently we've seen in the field of myeloma, we discussed this in this journal club, that some of the control arms were really performing much better than what initially have been observed when they were developed. And this is probably a learning curve. Okay, wonderful. So we alluded, and Didier mentioned the patient where you would like to have a CNI-free approach. So can we go through some of these patients? And we have, for instance, a comment from Dr. Rahul Bhargava mentioning the TMA risk with CNI. I believe this is a true risk, but is this like the only reason with renal insufficiency to avoid CNI inhibitors, or who are the patients where you would like to avoid CNI? Miguel.
I think that the main ones that we think of today in current practice are the patients like Didier mentioned, the ones who have renal impairment to begin with, and you're concerned about the added toxicity of a CNI. I think we all recognize that TMA is a complication and potentially severe complication of transplant. And we know some of the risk factors, but that's usually, I don't think, a main consideration pre-transplant in terms of selecting the GVHD prophylaxis. I think the renal impairment is the main one that stands out in my mind for where we would want to be CNI free.
Didier, you are in agreement?
Yes, I do agree, but I have a question related to, not to that, but to the use of CNI. Why could we be more innovative using CNI, notably talking about the duration of the treatment, which could be of importance in this situation? How long do you keep CNI in New York, or have you clues about this new strategy using CNI or not?
I think we're sort of quite traditional here, and we're still using it for 6 months or so. And I think, the post-transplant management of patients, unfortunately, I think is complicated because, conditioning regimens all get done at the same time. And it's much easier, I think, to have guidelines around, drugs that are given over a short period of time versus drugs that are tapered. I mean, we all know that once patients have GVHD, they can be on prednisone forever. And that, trying to mandate a rapid taper of steroids is always challenging. And whenever you put that in the trial, you get a lot of deviations and variations. And I think physicians tend to have a lot of variability in how they practice. So even if you have a protocol that says stop CNI by 6 months, when you go back and look at the data, you'll see that some patients at 12 months are still on CNI, and it's not clear why they were still on CNI.
Okay.
But I agree with you, we probably overtreat, and that leads to complications.
Thank you, Miguel. We have now a question which I believe is important, because more and more I think we all acknowledge that relapse is really the main concern. And one suggestion from this trial is that maybe with post-Cy you have less relapse. Although in the original publications from Hopkins, from Leo and colleagues, they showed a high rate of relapse. But here the question from the audience we have from a colleague is that more and more these days we're using maintenance therapy after transplant. And actually, it wasn't really the case in this trial because I've seen roughly 10%, 11% of the patient and less than 5% in the third arm who received maintenance therapy. Probably today, more patients would receive maintenance therapy. And we had a comment from, again, Dr. Avinoso about the MRD positivity, but for the sake of time, we will not go into these details because then it will become more subtle.
We don't have that data yet, so that's an easy answer.
Okay, well, Daniele, you have your answer. How would you today, if you have to do the same trial, how would you account for the maintenance therapy? Because that creates lots of confounding.
The approach we used in the trial was that any FDA-approved maintenance therapy was allowed, or therapy that was in a clinical trial. So, for example, patients were allowed to go on the gilteritinib phase 3 trial. So TKIs that were considered standard of care for Philadelphia positive ALL were allowed on the trial. You know, post-transplant azacitidine, which a lot of people use, was not allowed on the trial, because that was felt to be, one, not proven as a standard of care, and two, could be a confounder in terms of GVHD signal, which was a primary endpoint. So that's why azacitidine, you know, was not allowed, but the standard TKIs were allowed for the appropriate diseases. I think, you know, the question on hypermethylating agents post-transplant for relapse prevention is still an open question. I mean, the MD Anderson study was not positive. I think a lot of people use those drugs, but it hasn't been proven. And I've used it in patients too. So I think we're waiting. I'm waiting for randomized data. We're waiting for randomized data on gilteritinib.
Wonderful. So we're almost reaching the last few minutes of this fantastic journal club. So let's talk about the future. So one question to you, Didier. If you have today a grant, a very sufficient grant, and the capacity to include 300 plus patients as it has been done in this trial, what would be the ideal, I would say, randomized setting that you would like to test in this field? And of course, Miguel will have time to think about it while you're responding, because I'll ask him the same question. What is the future? You did this now, great trial. What's the next step? What are you going to build on this trial? So Didier, what would be your proposal if we offer this grant to you and everybody's committed to include more than 300 patients?
There is a if in your question, or you propose the grant to me?
We'll discuss this after the journal club.
First, I think we cannot deal with the whole transplant patient in the same way. And I will focus in older patient around the age of 60, 65, because I do think that's really the major impact we can have, because many of these patients are not yet transplanted, and we have to transplant them. That's the first thing. The second thing is that I will really privilege the safety of the procedure, because as just mentioned, we can use maintenance therapy, or we can use immunotherapy post-transplant using DLI in this situation. And if the patient is impacted by the conditioning regimen initially, he will not receive whatever the treatment you could give after. So I do think that we should think about transplantation more as a platform at the present time. The early days, we have to be safe. You have to keep the patient in good situation and include post-transplant treatment afterward. And my clinical trial will be around that to try to develop different aspects. And clearly, and it was mentioned by Miguel, I am not really in favor of using methotrexate, whatever the platform. So it's the reason why I would probably choose to use PTCY in this situation.
So Miguel, what's the next step now?
I mean, that you could go many different directions for that answer. I think I agree with Didier. We should look at what the unmet needs are, and those are sort of the older patient and the relapse issues. So I think trying to, develop studies in that setting is critical. This study, as well as the other Progress trials, including Progress 3, which hasn't read out yet, which is a RIC phase 3 trial of PTCY versus standard of care, were all meant to reduce GVHD because that's still one of the main complications of transplant. So I think in terms of GVHD reduction, we've seen recent approval in the US of abatacept. I think there are other strategies being investigated. So I think we have to see, where we go with the next trial. I think the issue of donor source is interesting, with the mismatched mud approach, which may compete with haplo. So I think we might want to see studies there looking at haplo versus other alternative donors. But I do want to comment on CD34 selection, since I've spent, a few years working on CD34 selection. What's the future of CD34 selection? Clearly not the way it was done in the trial. As I mentioned earlier, we're now doing different scheduling and dosing of ATG based on the work that JJ has done. And the early results are actually quite promising in terms of CD4 recovery already at 3 months in patients. Obviously, we have to see what that means clinically in terms of survival and NRM. But I also always have thought of CD34 selection as a platform for additional therapies, and particularly adoptive cell therapies, because you're not dealing with calcineurin inhibitors, you're not dealing with GVHD and steroids. And so, we're doing studies now with the Stanford group, with Orca Bio that has the Treg TCON, which is based on CD34 selection. We're also doing a study with Vor Bio, which has a CD34 graft that's CD33 depleted by gene engineering. They take out the CD33, and then you can treat patients post-transplant with either Myeloablative to target CD33 or potentially a CD33 CAR T cell. And again, this is done in the context of a CD34 selected graft. So I think that's where the future is for CD34 selection, is to take advantage of the fact that you can, get a graft in with low risk of GVHD and no need for immune suppression, and try and improve the outcomes with post-transplant adoptive cell therapy.
Wonderful. Thank you very much, Miguel. I think really it's a very, very exciting era for all of us in the transplant field. And I believe while everybody's excited about drugs, actually in parallel, the transplant field is also moving forward. And definitely there are lots of patients who are in need, and allotransplant is definitely a curative treatment approach. And actually the results from this trial, although some of them were unexpected, but overall they really highlight, I think, the advances we've made in the transplant rate mortality of less than 8% at 2 years is really a big achievement. So again, congratulations to you, Miguel, and to the whole team. Thank you, Didier, for taking the time to have this in-depth discussion about this article. We're looking forward for more and more similar studies. So our next journal club is in 15 days. You will discover the announcement as usual. 2 journal club sessions broadcast per month by the IACH. But also don't forget, guys, January is usually the month of the post-ASH activities of the IACH. So I'm pleased to announce that on the 18th and 19th of January, you can book your calendar. You will have 2 double-header webinars by Dr. Bipin Savani, and he will summarize all the transplant and CAR T-cell data from the last ASH meeting. Then on January 27th, you will have Dr. Zedan Amer from Yale, who will give you a summary about the MDS data. We are planning an MPN summary post-ASH by Dr. Naveen Pemaraju. And of course, we will have our traditional post-ASH roundtable discussion about the myeloma data. So you will see lots of activities waiting for you during the months of January. So please stay tuned. And again, wherever you are, please stay safe and keep well. And if you have joined during the webinar, during the Journal Club, Happy New Year and best wishes. Thank you, Miguel. Thank you, Didier. Take care.
Thank you.
Thank you. Bye, everyone.